really want to just hand over directly to James from Givewell to give us an overview of Givewell's approach to cost effectiveness and offering recommendations for charitable donation.
So thanks a lot, Alice, and thank you to everyone for taking the time to come to the webinar today and also to being so patient while we had those technical difficulties. So my name's James Snowden. I'm a researcher for an organisation called Givewell. I'm just going to give a brief introduction to who we are and what we do before touching on a few points on how we make decisions which might be of shared interest. So I just want to make it really clear at the outset that I'm not claiming to have a special expertise in the humanitarian sector. I tend to work more on longer term global health issues and economic empowerment. So I'm coming at this from the perspective of this is how we prioritize as a funder. Let's work out if there are kind of general applicable lessons here that we can both learn from, rather than, you know, we're the experts and this is how you should do it. So who are Givewell? So we're an independently funded non-profit that was started 10 years ago by two donors who were trying to work out where they should donate to maximize their impact. And generally found there just wasn't enough information available to answer their questions. So they ended up quitting their jobs and just trying to create or starting Givewell. So we look for evidence-backed, cost-effective and underfunded giving opportunities in global health and development. And we publish all our reasoning online. We're committed to radical transparency. So if you go to our website, you can see all our reports. And unusually, I think we also publish all our spreadsheets, so you can see the assumptions informing our recommendations. We also record all the conversations we have with external experts and put those conversation notes online, which can be a useful resource in a number of different areas. We also actually record all our board meetings and put the full recordings of them online, but I suspect they're only interesting to people who are really obsessed with our work. So just for context, we move about $100 million of donations a year, and that's from a combination of smaller donors and larger foundations. We recommend 9 top charities across 6 different intervention types, largely focused on global health, but also in economic empowerment. And you can see those, the interventions that we recommend there. So deworming, long-lasting insecticide-treated bed nets, seasonal malaria chemo prevention, vitamin A supplements, unconditional cash transfers, and our newest top charity, which provides incentives for seasonal migration during the lean season in Bangladesh. How do we identify our top charities? So we generally have historically had 3 methods. So the first is what we've used the most. It's identifying priority programs based on a literature review. So we look for programs which have a lot of evidence behind them, a lot of high quality evidence, and then kind of start doing initial models to estimate how cost effective they might be. Then we prioritize assessing charities doing those interventions. For example, there's a ton of high quality evidence that insecticide treated nets cost effectively reduce child mortality from malaria. And Against Malaria Foundation, which is one of our top charities, is a highly transparent organization that purchases and distributes these nets. Unfortunately, there's a very limited number of programs where we have this kind of evidence, an even smaller number where we can identify as a suitable charity. So we also make incubation grants earlier in charities' life cycle to charities that we think are promising and are likely to become top charities in the future. So for example, we provided seed funding to the Center for Pesticide Suicide Prevention, which is an organization that advocates for regulation of pesticides commonly used in suicide. And there's some quite controversial evidence that pesticide regulation was partially responsible for a 50% reduction in suicide rates in Sri Lanka in the 1990s. Our best guess is this could be a very cost-effective organization. So a third method we use is just we get suggestions from networks, from people who we think share our values and our attitude towards evidence. So for example, Evidence Action, which runs one of our deworming programs, came to us with high quality evidence that incentives for seasonal migration during the lean season in Bangladesh had a large effect on future income. And that charity has now become a top charity this year. So when we're assessing these programs, we focus on 4 criteria. And the most important of these is cost effectiveness. So the 4 criteria are cost effectiveness. So how much good can we do per dollar? And that's based on our best estimates. And the second is evidence of effectiveness. So how strong is the evidence that this program works? So if you distribute anti-malarial bed nets and they're used, what effect will that have on mortality? And importantly, I think we focus on outcomes like deaths prevented rather than outputs like number of people reached, because we don't think that's a particularly good measure of how effective a program is. The third thing we focus on is transparency, monitoring, evaluation. So do we have sufficient information that the charity is actually causing its outputs to happen? And the fourth is room for more funding. Can the organisation productively absorb additional funding? So these things, the second, third, and fourth criteria all kind of feed into the first. So cost effectiveness is what we really care about. It's how much good can we do per dollar on the margin? So how will additional funds to this organisation cause additional good outcomes to happen? And you can see that each of those three criteria kind of feed into that top level criteria. And I should just be explicit here that we're looking for the best giving opportunities we can find, and there's room for judgment here. So these criteria might be applicable in different ways to different organisations. But this is our kind of broad framework for thinking about it. So I think an important question here is about what our attitude to evidence is and how we assess evidence. So I think I'd define evidence very broadly. So it's any data points which would just shift our prior beliefs on the cost effectiveness of an organisation. And some types of evidence are just more likely to shift our priors than others. And there are generally two dimensions that we evaluate evidence on. So the first is how reliably it identifies a causal connection in the context in which that particular study was set. So ideally for that, you want a randomized controlled trial. You're failing that, a quasi-experimental study. And then we generally tend to be very skeptical of correlational studies because there's a number of ways in which they could misrepresent the causation that's going on there. And the second question is, well, maybe this program was very effective in this context, but would we expect that effect to generalize in a way that would be applicable to our charities? And that's something that's often very difficult to do and requires a lot of judgment. I think one important point here is it's generally easier in health than in other contexts because you have a kind of assumption of similarity where health interventions, if they work in one context, will generally work in another. Once you control for different levels of rates of prevalence and kind of a limited number of different factors. But of course, when you're assessing evidence, you need to make judgment calls, and it's not about awarding different studies different points for how strong they are. You have to look at a broad array of evidence and ask yourself, well, what's the most plausible theory that's compatible with all of that, including the possibility that some of those studies might be flawed. It's also important, I think, to use different kinds of evidence for different questions. So if we're trying to work out the effect of distributing a bedness or mortality, then RCTs are a very good tool for that. If you're trying to make your best guess about how valuable it is to raise income versus health, you need to look at stated or revealed preference studies. So different kinds of evidence are useful for different questions. And we need to answer a lot of different questions to come to an overall view of how cost effective we think an organisation is. So what do we mean by cost effectiveness? So I think distinguish between two kinds of cost effectiveness. So one is conceptual, which is just how much good can we do per dollar spent, where good is broadly defined and where we put kind of our best guesses of the different amounts that we weight different good outcomes into our model. And that's kind of if we knew everything about the world, that is our end goal. That's all we care about. But then there's another kind of way. I think the way that people normally use the word cost effectiveness is to refer to just what's the answer in our spreadsheet model. Now, we can't include all the relevant considerations in our cost effectiveness analysis, but we try to include as many as we can, and then be as explicit as we can about different qualitative considerations we're also taking into account. So I think where we differ from how many people use cost effectiveness analysis is we're more ready to put subjective guesses into our analysis where we think they're relevant for our decision making. So for example, we assign quantitative weights to different good outcomes, not because we think we've solved ethics, but because we need to ensure consistency and make sure we're thinking through all the relevant considerations. And also, just to be explicit, so people who can disagree with us can be specific about why. They can say, well, I actually, I disagree about how much you're valuing health relative to wealth. And then you can actually have a discussion about that. So you need to put numbers on these things because the question isn't just do they matter, but how much do they matter? And that's impossible to do with just qualitative arguments. Now, this is quite different from how academics do cost effectiveness analysis, where there's less room for judgment. But I claim it makes cost effectiveness analysis more relevant for actually making good decisions. So where we can get good estimates, we do so. We review the academic literature to work out what the expected effect of a particular intervention might be on mortality. But for our most uncertain inputs, the best way we've found to do this is just to ask all our staff what their best guess is, and then come together, discuss that, and adjust our best guess based on that discussion. Now it's pretty unlikely we're going to reach consensus. So I think the best way, once we've done that, is to just take the median of our staff values. And you can see what those are in our spreadsheets that are available on our website. And I just kind of, if you had to take one thing from this presentation and you know, what I believe about how to make good decisions, I really can't emphasize enough the importance of putting numbers on things. And that's even when they're very difficult to justify. And I think this isn't just about the humanitarian sector or global health or development. This is just how you make good decisions across a number of different domains and be explicit about the reasoning for those decisions. And just to address the point that Barnaby and Alice were talking about earlier, and that's, is this a science? Well, I think it is a science, but not in the sense of bean counting or only relying on really strong objective evidence. And I would argue that's not actually what the scientific method is. Science is about being explicit about your hypotheses and then testing those hypotheses to find out why you're wrong. So in that sense, I'd say we are striving to be as scientific as possible. So I think the final point on cost effectiveness is it's all very well for us to build these models, but you really have to do this in collaboration and conjunction with the organizations we're evaluating. So they often know a lot more about their projects than we do. And I think that's the kind of the classic funder's dilemma, is you're making decisions about where to allocate funds based on a relatively high level knowledge of what's going on. So one helpful thing we found is just sending our spreadsheets to people who know more about the project than we do and asking them where they disagree. And the advantage there of putting numbers on things is that you can be very specific about, you know, this is why we disagree. So that's a kind of whistle-stop introduction to how we prioritize. I've gone through it quite quickly. I think it's probably missed a lot of nuance. So if you have questions, I'd encourage you to ask them either in this webinar, check out our website, or follow up at info@givewell.org. But finally, I just wanted to conclude with some thoughts about how our approach might be relevant to the humanitarian sector. And I want to be extremely modest about my claims here, because many of you will know more about the particular challenges faced by the humanitarian sector than I do. But I do have some kind of general thoughts on what might be applicable and some of the challenges faced. So I think two generally applicable points. First is that quantitative reasoning is really helpful for prioritization, not because we can reduce the world to a simple spreadsheet, but because it really makes you think through the relevant considerations and think, how much does this factor matter? How much is it influencing our decision? If this factor wasn't true, or if it didn't take into account, would that make us change our mind? It also helps make your assumptions really explicit, so you can change your mind based on new evidence or invite disagreement. And the second, I think, which is related, is just to be as transparent as you can. And I think this will apply different amounts to different organizations. I think it applies very strongly to funders, who often just don't have to justify their work to the public. So nobody can disagree with you if they don't understand why you make a decision. So circulating your reasoning around relevant stakeholders, at least within the organization, and in an ideal world, publishing all your reasoning online so donors can understand why you're making the decisions you're making. I think this is highly relevant to humanitarian funders, but also large NGOs who are trying to decide between different programs they could do. Now, I also recognize there's a bunch of issues that make this kind of analysis harder to do in the humanitarian sector. And this is one reason that we haven't prioritized doing a lot of work in the humanitarian sector relative to other work in global health and development. So I think the first is, there's generally just not as strong an evidence base for what works in the humanitarian sector, or at least that's my impression. Whereas in health, you have tons of randomized controlled trials, you have meta-analyses, and you can generally base your decisions on quite objective factors. That often just doesn't exist for more complex interventions. The second, relatedly, I think external validity is a problem. So again, for health, generally this assumption of similarity holds reasonably true. I think this is less the case when you're talking about a very diverse set of interventions. And the third is that obviously in the humanitarian sector, you're often responding to urgent crises, and you have very short timescales, and that does make careful analysis quite difficult. So I think there are reasons to be cautious of this approach, or at least taking it wholesale for the humanitarian sector. But I also think there are some kind of general lessons that might be applicable. And those are, around transparency and about being explicit about your assumptions and why you're making the decisions you're making. So yeah, thanks for listening, and I'm looking forward to the discussion later.
Great, thank you so much, James. Really interesting, a lot to draw on there. Just a quick follow-up question. When you talk about the moral priorities, because I think that's an area where, we were talking about, is it scientific or not? And yes, I think you have a really great point there about it's about testing hypotheses and being really clear about how we get to the information or what information we have to interrogate those hypotheses. But also at the end of the day, there's a moral question there about values and priorities. So I wonder if you could give maybe just an example that might be off the top of your head of this kind of moral weighting that Givewell has done, and then also posing that Save the Children question to you that we discussed with Barnaby a few minutes ago. What your thoughts are on that kind of dilemma between kind of political activism versus direct response, and how you or how Givewell would think about weighing up those different options.
Sure. Yes, that's a good question. So maybe first I'll discuss some of the maybe like moral dilemmas that we faced in our work. But first, just the process that we use for it, I think, is probably the most generally useful thing, which is going out to all our staff, asking them to make their best guesses, inputting that in this spreadsheet, and then coming together and having that discussion and changing your values based on that. So to take maybe two specific examples, one is how should we value health relative to income? Now, I'm not sure there's an objectively correct answer here, but I do think there are answers that are better than others. If somebody told you that they'd rather give a rich person an additional $1 than save a life, I think that would just be crazy. And so there's value, at least in surveying what people's best guesses are and then taking that as a reasonable range. In practice, I do think there are pieces of evidence you can point to just think about this a bit harder. So I think one is there's a bunch of, and this evidence is limited in a lot of ways, but there's a bunch of studies that go out and try and work out how the beneficiaries themselves go about making these decisions. So that's often based on revealed preference, which means there's very limited evidence in developing country context. So largely so far we've relied on developed country studies here, which might well be very wrong, but we're using them as an input to our analysis. And then so one thing we're actually trying to do to kind of get a bit better at this, and I'm quite excited about this project, is we're partnering with a group called ID Insight, who are going to be working in Kenya to collect data on how people in Kenya make these trade-offs. And I think that's going to be a very important piece of evidence that might well shift our priors on what the right or what a better answer might be there. And to give another example, so I mentioned before the Centre for Pesticide Suicide Prevention and their work. So an important question there is, how much do you value preventing a suicide relative to preventing a death, maybe from malaria or another preventable disease? And there's a bunch of difficult intuitions here, and I've certainly heard people make the argument that, well, if people want to commit suicide, that it's not our place to stop them. And I'm sympathetic to that. I kind of feel like there's it often gets conjoined with the debate on euthanasia. On the other hand, if you actually look at the evidence, there is some suggestion that this isn't a kind of permanent preference that people have. And actually only about 5 to 10% of people who attempt suicide and survive will then reattempt. So I think that's an example of how you can use evidence even to answer questions where there is maybe no objective answer, or that you can be completely confident in, but just to kind of make better decisions. And then the question that I see on the screen here, so I think this is a good question. I have a fairly I just to talk about my own beliefs here, I have a fairly strong view on this. So the first point I'd like to make is in this discussion, and maybe you've already discussed this, you've talked about how many people you're targeting, but I just don't think that's a useful metric. So there actually isn't enough information here to come to a good judgment. You need to look at how many lives you actually expect to save and come to a judgment on that. And maybe you're not going to have objective evidence on it, but you actually just need to make an explicit guess. So to address the question more concretely, so if you're assuming you could raise the money for either program equally, and also assuming empirically that you could save more lives for the same cost by funding the vaccination program on the margin. I think it's fairly clear that that's what you should do. You should fund the vaccination program. I mean, our role as funders and NGOs is to do as much good as we can per dollar. But I think there are kind of empirical reasons why this might not be true. I mean, is it true that you can do more good by funding the vaccination scheme? I can think of two reasons it might not be. So the first is that you wouldn't otherwise have been able to raise that money to send out a search and rescue team. And if that's the case, then I think that probably would be the better thing to do. It's true that it's a better use of money than those funds being spent on private consumption. And I don't think anyone would disagree with that. But the trouble is, I think it's likely that more marketable causes are at least partially displacing funds from less marketable causes. So just from the kind of entire societal level, I think there is an issue there that we've got to be very careful about. I also think it's a very dangerous precedent to set to determine your programming by what will enable you to raise more funds. Because as an NGO, you're typically in a much better position to determine what will be more effective than donors. Now, I do, of course, recognize that there are kind of various constraints in reality that we face. So I think, and this is something that we're trying to change, I think. It's the way that donors think about giving. So from Givewell's perspective, we certainly wouldn't be interested in funding any organization who determine their priorities based on what donors thought. And if you disagree with us about what we think the most effective use of funds is, an NGO should make that case to us, and we can have that discussion. And I do think we need to create a better dialogue between funders and NGOs. I'm not particularly blaming NGOs for this. I think you're following the incentives that donors set for them. But I do think that's something that we're trying to change. And in the context of this is the reality of the humanitarian aid system. Well, of course, we all operate within certain constraints, and we have to recognise that. But I'd argue that there is a large sense in which we are the humanitarian aid system, so we get to choose what that reality is. Now, so I've talked for a while, but just want to make the second thing, which I think is a better argument, which is that you might be raising the political profile of an important cause in a way that's very difficult to measure, and that should, of course, play a role in the decision. Now, I certainly agree this seems like a relevant consideration, and I'd be very suspicious of anyone who doesn't approach questions like these with a lot of epistemic modesty, because these things are just very difficult to predict. But I think you have to be very careful to work out what your actual goal is here and how you'll know if it's successful. So if you've made the decision on the basis of raising the profile of a cause, presumably you're targeting some kind of political change. Well, what is that? And how will you know if it happens? And if it does fail to materialize, I think you have to be ready to go back and say, well, that was actually the wrong decision, because we've made this decision based on trying to create this political change, and that hasn't happened. So I think there's also a plausible argument that funding search and rescue would actually have the opposite effect. And I don't, I wouldn't stand by this strongly, but by you could displace government funds on that issue and smooth over the cracks somewhat. Although I guess you could say the same thing about vaccines. And just finally, a third point here around equity and prioritizing helping those who are worst off. Well, I guess I don't think there's a morally meaningful way, and this is my own views here, not Givewell's, but I don't think there's a particularly morally meaningful way in which someone who drowns in the Mediterranean is worse off than someone who dies from a preventable disease because of lack of vaccination. In fact, if anything, I'd say it was the other way around if I had to guess, because infectious diseases typically kill very young children, and I can't think of anyone who's worse off than a very young child who dies in that way. So yeah, so that's my view. Yeah, sorry I've gone on for a while.
Right. No, that's okay. It's all very interesting. I wish we hadn't lost so much time to the technical issues, but really a lot of food for thought and a lot of great points that I think we need to be discussing more in the humanitarian sector, especially your point around having these open conversations between funders and implementing agencies. I think there's a lot of institutional governmental donors who would agree with you there. We're going to turn to Josephine, and we will go 40 past the hour to make up for some lost time and to ask Josephine her thoughts on a couple of these cases. But initially, Josephine, we wanted to turn to you to explain how resource allocation is approached in public health systems, and particularly to explain to us, unpack, for us these complex notions of the QALY and the DALY measures and how those are used. Over to you, Josephine.
Okay, thanks very much. I'm going to, as you said, just talk a little bit more about the concept of economic evaluation that James has been talking about, and I'm going to start just by asking a question about the relevance of economics to healthcare in general. And this is a question that, as health economists, we often get asked, particularly those working in the medical profession feel sometimes quite uncomfortable. About the application of economics to health, and there's a sort of question about whether you should be putting an economic value on a human life, but I would argue that it is relevant. So why is economics relevant? Well, essentially, if we had unlimited resources, there wouldn't be an issue, but we live in a world of scarcity, so resources are not unlimited, and therefore we have to, as we've heard earlier in the session, work out how to prioritize and allocate those limited resources across the population. And implicitly, when decisions are taken about how to invest resources, there are a set of criteria and values going into that decision. But if those criteria aren't made explicit and transparent, then it's hard to judge the value of the decision. So what economic evaluation is really trying to do is to make those criteria and values explicit and transparent. And essentially what it does is it compares systematically the costs and the consequences of two or more alternative courses of action. So considering the costs and consequences of investing, for example, in malaria prevention versus HIV prevention. Economic evaluation can't answer all our questions, so it cannot tell you whether or not a particular program should be funded. So really what it is doing, it's providing you with information about the costs and the benefits of alternative courses of action. And this, in addition to clinical, social, ethical, and political data, can help inform decisions. So it's only one piece of information that should feed into the decision-making process to assist resource prioritization. But I would argue it's an important one. Now, there are different types of economic evaluation. We heard from James about cost-effectiveness analysis, which is most widely used in the health sector. We sometimes refer to this as cost-utility analysis when we're using QALYs and Dalys, which I'll talk about in a second. But there were other sorts of economic evaluation, like cost-benefit analysis, which measures outcomes in monetary terms. So essentially what distinguishes the different forms of analysis are the way we measure outcomes. So let me talk a bit more about what I mean by outcomes. So if we think about a program, for example, a cash transfer program aimed at improving access to healthcare, you could measure the outputs associated with that program, so the number of the amount of cash transferred to different population groups, for example. So that's very important programmatically because it tells you about implementation and how your program's working in practice. You could also measure how that cash transfer is affecting the population in terms of their behavior. So looking at healthcare utilization rates, for example, as intermediate outcomes. So while those two types of measure are usually captured within program evaluation and are useful for programmatic relevance, they're not very helpful for economic evaluation because, as I mentioned, economic evaluation is about comparing interventions with each other. And so what you want ultimately is to have an outcome measure that is sufficiently sort of generalized that it allows you to compare across all different types of interventions. So if moving away from the intermediate outcomes, oftentimes we might measure, for example, health outcomes. So what impacts a program having on mortality rates, on morbidity in a given population. So that's a useful outcome in that it will allow you to compare with other interventions targeting the same condition. So for example, if it's a malaria intervention and you have information on malaria deaths, you can compare with other malaria interventions. but it wouldn't allow you to compare with an HIV intervention that's having a different type of health outcome. So this is really where Dalys and QALYs come in. So Dalys are disability adjusted life years, QALYs are quality adjusted life years, and we refer to these measures as generic outcome measures. Why they're generic? Because they allow you to compare interventions of any type within the health sector. What they don't allow you to do is to compare an investment in the health sector to an investment, say, in the education sector or transport sector. So if you wanted to do that, which I can imagine might be the case in the humanitarian sector, you would need to go one step further. You'd need to actually put a monetary value on the outcomes that you're getting from your intervention. So what you'd do is you'd itemize all your different outcomes, and then you would, I mean, there are different ways of working out a monetary equivalent for those outcomes. So then essentially you'd be comparing the cost of your intervention with the economic benefit, monetary benefit of the intervention. But I'm going to focus here a bit more on the Dalys and QALYs, because these are what are most widely used in the health sector. So Dalys, these have been essentially the measure that we've used in lower middle income countries. So Dalys were first established not for cost effectiveness analysis purposes, but as a measure of the global burden of disease. So to work out and compare across countries what the burden of disease was in overall. How are Dalys measured? How are they estimated? So they combine, in the same way that QALYs do, a measure of an impact of a program on mortality as well as morbidity. So what we're doing is you're adding the years of life lost from premature death due to a particular health condition, let's say HIV. You're adding to the years of life lost an estimate of the years of life lived with disability associated with that same condition. And to get an estimate of years of life lived with disability, you need a measure of disability weight. So what the global burden of disease exercise did essentially asked a set of experts to look at a whole range of different health conditions and to establish and agree on disability weights for each of those decisions using a preference rating method called person trade-off. So each health condition has an established disability weight, which is adjusted according to different regions. And in the worst case of death, that weight would be 1, and in the best case of perfect health, it would be 0. So it should be clear that Dalys are a bad thing, so they're a measure of ill health, and so what you want is for your program to avert Dalys, to reduce the number of Dalys. I should add that Dalys, in the way that they've been calculated in a lot of studies, they actually make some adjustments for the age of particular individuals. So what they do is that they value life years, so productive life years, so between ages of sort of 15 to 45 more highly than younger years and older years. So that's a sort of a subjective decision that was made by those that created the Dalys, and so that age weighting is sort of built into the Daly calculation, although it is obviously possible to calculate Dalys without introducing any age weighting. So if we look at a concrete example of how we might estimate Dalys, let's consider the case of a Chilean woman who becomes affected by bipolar depression at age 35. Now, in the absence of treatment, this woman would only live another 10 years before dying. And during those 10 years living with bipolar depression, she would have a disability level or disability weight of 0.6. So if she'd been in full health, the weight would have been 0, but because of this condition, it's 0.6, and then she would die. Now, if treatment were available for this woman, she would be able to live her entire residual life expectancy. So in Chile, that would be an additional 44 years, with a disability reduced to 0.3, so half of the level of disability that she would have without treatment. So then what we can do, we can calculate Dalys. And within these calculations, I haven't included the age weighting, so just to keep it simple. So with no treatment, if you remember, the calculation is essentially adding together the years of life lost due to the condition with the years of life lived with disability. So in the first case, no treatment, essentially we're talking about 44 minus 10, so essentially 34 years of life she's lost because she lived only an additional 10 years instead of the 44 years she would have lived with treatment. So that's 34, and then on the life lived with disability side, she's living an additional 10 years at 0.6 disability. So we're basically adding together 34 plus 6, and that makes 40 Dalys. So essentially, we're saying that living with bipolar depression at age 35 without treatment corresponds to 40 disability adjusted life years. Now, if treatment were made available, the woman no longer has a reduction in life expectancy. She continues to live as long as she would live in perfect health. So the years of life lost are 0. So what we're adding there is essentially just the years of life lived with disability, which are the additional 44 years of life lived at 0.3 disability. So that's 13.2 Dalys. So you can see that the treatment in this case is averting or eliminating 26.8 Dalys, so almost 27 Dalys. So what about QALYs? So QALYs, quality adjusted life years, are a measure that has been most widely used in high-income countries. And essentially, like Dalys, it's combining a measure of life expectancy with quality of life. And QALYs, the concept of a QALY was established by a health economist with the explicit aim of feeding into economic evaluation, unlike Dalys. So how do you calculate a QALY? Basically, you look at the remaining life expectancy that an individual has living with a particular health condition, and you multiply that by a measure of the quality of life in that condition. And in economics, we tend to talk about the utility that the person experiences in that particular health state. So if a person was in perfect health, their utility or their quality of life would be 1. And if they were dead, their utility or quality of life would be 0. So you can see, hopefully now, that this is pretty much the converse of a Daly. It's like the sort of mirror image of a Daly. In terms of how these utility weights or quality of life weights are derived, so unlike Dalys, they don't come from an expert panel and they're not fixed. They come from surveys of patients that are living with a particular health condition. And there are various different methods for eliciting those preferences from patients. And one of the reasons why QALYs haven't been used in lower middle income countries to the same extent is because these surveys have been validated in high income countries, but not in low income countries. Obviously, there are costs associated with collecting data from patients as well. So a variety of reasons, whereas in the Daly case, the weights are published, publicly available, so anybody can access them without having
Josephine, just to jump in there, because it's really helpful, really clear, aware of the time a little bit, just really
Oh,
quickly.
sorry. Yeah.
Oh, no, it's okay. Just that there was a question submitted by the Belgian Red Cross beforehand asking about would you consider using cost per Dalys or QALYs as the basis for deciding upon humanitarian interventions to finance? And so I just thought quick reflections from you on that issue. You know, because you're just talking about how the QALYs are more difficult to apply in lower income settings. So would you consider the cost per Daly or QALY as a basis for deciding upon which humanitarian intervention to finance?
Okay, thanks. Yes, so I mean, if possible, yes. I mean, ultimately, I think that's what we should be aiming to try and do. I think given the context, looking at cost per daily is probably the most practicable. It's probably not going to be feasible to undertake a survey at short notice of patients, and most likely the setting that you're working in, there wouldn't be the surveys wouldn't have been necessarily validated in those settings anyway. So DALYs are probably the best option. However, the difficulty is in order to calculate a DALY, you do need data on the impacts of your program on mortality and on morbidity, ideally as well. And that isn't always available. So one of the challenges we often run into when we're trying to do these kinds of studies is the best measure of outcome we have is, you know, the impact of a program, say, on healthcare utilization. So then we have to try and work out how to get from there to an estimate of mortality effects, you know, how likely that increased utilization is going to be to reduce mortality. And there are models that exist that allow you to do that for certain health conditions. And you can also obviously use the literature to try and inform and make assumptions to make that, you know, to make that jump to DALYs from a more intermediate level outcome.
Great. Well, thank you so much. I know we're going to be hitting up against time here. Maybe Barnaby, if you have a few minutes just before we jump off, and thank you so much, Josephine. We have a lot of questions that people submitted, but what we might do here is provide those to our panelists, and they can answer them by email, and then we'll put them up online afterwards on the website when we distribute the audio. The audio recording. Just some reflections back from you, Barnaby, on what you've heard and kind of sandwiching the whole hour and a half here. What are your thoughts on some of the views and approaches that James and Josephine have offered here, and how you think they can help address some of those challenges we were discussing at the top of the hour?
Thanks. I mean, I'm really interested to hear the presentations. I think we need a lot more of this sort of exchange from other sectors into the humanitarian sector. We really need more of this kind of rigor, these kind of approaches that focus on evidence, and some of the concepts that James and Josephine have talked about. I guess the challenge is that, you know, we're a long way away from that. Well, we're a long way away from that in terms of the culture. The contexts are, as James said, very difficult to even, you know, interesting. Josephine saying it's hard to get these sort of calculations in, you know, in some of the studies they're doing. Trying to do that in more difficult, challenging, conflict-ridden places, even harder, I guess. So I suppose in terms of what I take away from it is, you know, I have a scientific background, so I have a huge amount of sort of sympathy for more evidence, you know, better data, and using that in a way that's transparent. I think these are all things that we talk about a lot in the humanitarian sector. Trying to get it done is really hard, partly because of the kind of culture of things need to get done now. Partly, I think there is a sort of, you know, you can get away with a lower bar because it's a difficult situation. So I think there's a responsibility on donors to try and find areas where we can actually do this stuff, because, you know, it's easy to look at, well, you can't do this in Yemen or Syria, but, you know, refugee health settings, you know, in camps, those are much more akin to the kind of places where you can actually start to do RCTs. You can look at, you know, cash transfers, I think you mentioned as well. That's something that's more amenable to these sorts of approaches. I think what it needs, and this goes a little bit to the question that you mentioned from the Belgian Red Cross, is, you know, how much you know, are donors and others prepared to invest in trying this stuff out, piloting it in areas where we think it might work, you know, shadowing decision making based on some of these kind of evidence-based approaches, and seeing where it's possible. You don't have to choose the most difficult place to do that. Try it somewhere where it might be amenable, in a refugee camp. You know, cash transfers, not in a kind of rapid onset situation after an earthquake, but again, you know, refugee settings where that's a bit more amenable to the kind of longer term basis that you need to build up the right infrastructure and the right skills to do this stuff. So overall, I think we've got a long way to go, but I think we need to do more of this. Final word is, I think, you know, ultimately a lot of these decisions aren't, you know, the best evidence in the world doesn't influence the decision, because it's primarily political, and I think that's a big challenge, but that doesn't mean we shouldn't try and get the evidence in the first place.
Great, thank you so much, Barnaby. Really, really helpful, and I think great final remarks for us today. So I'm just going to thank the patience of everyone online, and thank our panelists, and maybe turn over to James and Josephine for just final remarks from your end on picking up on any of the kind of cases that we shared with you beforehand. What you think are some of the key things that humanitarian actors can do to improve the way that they use evidence for resource allocation, or the way that they think about resource allocation. So maybe starting with you, James, and then ending with you, Josephine. If you can keep your comments to just a couple minutes, that'd be very much appreciated. Thank you.
Sure, thanks. So yeah, I think this was an interesting discussion, and I do recognise the challenges that exist in the humanitarian sector. I guess my high-level point, which I was rather banging on about during my presentation, is that there are quick ways to do this, and I distinguish between, you know, one, having really strong evidence, and two, just making your assumptions explicit and kind of really knowing why you're making a decision. And I think the latter is something that's actually fairly not easy, but it is something that is amenable. You know, whatever sector you're working in, and not just in development. So I guess that would be my kind of overall takeaway.
Great, thanks so much. And you, Josephine, final thoughts?
Yes, so I just wanted to say, you know, obviously, you know, as far as possible, it's desirable to base decisions on economic evaluation information, but I obviously recognise it can be practically challenging, and the data might not always be available to support that type of analysis. But I think imperfect information is better than none. And as James said, you know, where possible, make assumptions, make them transparent, and start to build an evidence base on cost effectiveness for humanitarian interventions that others can draw on. So I think there's real potential for more use of these methods in the humanitarian sector. So yeah, thanks very much. I really enjoyed the discussion.
Great, thank you, Josephine, and sorry there couldn't be more of it, but please send us any additional questions that we couldn't get to, and as we said, we'll endeavor to post some short responses to those online afterwards. So thank you very much, everyone, and hope you have a fantastic rest of your day.